All right, so end of life. All right, so we're talking about things that need to be addressed at end of life and things that actually should have been brought up many months, many years even before other treatments were brought up, because oftentimes we spend the most amount of our money at the end of life, the most amount of time we want on this earth. We often say, oh, I want the most longevity out of life, but then actually was that longevity to have quality to it, or was it just a number, right? So that's one of the things we're going to approach is, do we do every treatment known to man that we can do, or do we do the treatments that the patient wants and that the family wants? Okay, we have to make sure they're all on the same page too. So we have to make sure the patient and the family are on the same page, because sometimes the patient is incapacitated, right? And the family is the one making the decision, and they've never talked about this, right? Or they have talked about it, and now they want to reverse what the patient wanted. Okay, so we talk about that, and then of course we've kind of touched on a few other pieces throughout, as far as like ALS and MS, about medically assisted medical aid in dying, or physician-assisted suicide, and that topic. All right, so we'll talk about end of life. All right, so life expectancy in the 1800s or so, 19th century, was about 47, right? So that means I have about 7 or 8 good years on this earth left, right? So that was it, 47 years old. You know, Meemaw got pneumonia. Okay, let's drive out, let's drive our wagon out to Meemaw's house. We're all going to be around her, and Meemaw is going to die, all right? Antibiotics weren't invented until the 30s, and everybody died of pneumonias, right? You got the pneumonia, TB was rampant in the West. Everybody's coughing up blood everywhere, right? So that was, they're not doing great. Get all the family together. We're going to gather together, and we're going to be with them as they die, right? Where that was the goal, right? Having family central to the dying process, right? Once you had an acute illness, you may die from it, right? So within the 20th, 21st century, antibiotics came. We had the 1930s. Now you don't die from pneumonia. You still do die from really, really bad pneumonias, but it's like just a regular old pneumonia. You can survive, right? So infection control improved. There was mass vaccinations and immunizations that we did. Everyone that came to America got vaccinated and immunized. It was a big thing, big development to prolong people's life. So people didn't die of rubella. People didn't die of measles or mumps anymore. And measles is extremely contagious. If a boat gets it, the boat's going to get it if they're coming over to America. So everybody got vaccinated. And then we had antibiotics, like we mentioned. We had water sewage treatments that were developed before. We let the water and the drinking water and the sewage water go in the same pipe. That was cool. We just did that. But now, you know what? Some guy came along and said, well, I'm putting in different pipes. Let's try this, right? So they put them in different pipes, and they actually started treating the water coming to the apartments and houses as well. They started treating the water to get rid of any kind of bacteria. What bacteria? Well, we hand washed, right? We had Semmelweis, and I found out that Semmelweis is now a musical in Britain. Anyways, Semmelweis he developed hand washing. He said, well, how about guys, after we touch the dead bodies in the cadaver lab, and we go do a perineal exam on the women in the OB unit, why don't we wash our hands? Just saying, right? So they say, you're an idiot. What are you talking about? And they found that less women died. So they said, well, let's go ahead and find out what the reason is. Okay, we had improved surgical techniques. So people started, did whatever they wanted. Right? So I amputate with a saw. I amputate with the same saw I used for the beef. I amputate with this saw. I got this other one. But now we had our same exact technique for how to amputate, or how to do an appendectomy, or how to do a bowel resection. Before it was just everybody had their own idea of how to do it, right? And we started developing what's called evidence-based medicine. So evidence-based practices are doing what had the best outcomes. Someone started keeping track. Otherwise, it's just fooling around. But if you actually start keeping track, that's called science, right? So they started going, saying, why don't this had the best outcome when we did the appendectomy this way? Why don't we do it this way, right? So the other thing also in World War II, there's a lot of ethics behind that, because they started doing a lot of experiments on humans, which is not very ethical. So, but we got a lot of science, a lot of answers made, but they were unethical. But we did evidence-based things. We did statistics and said this worked better than this did. Okay. And then what are the best medications? So like in the 80s, 90s, 2000s, we started saying this is the best medication for this cancer. This is the best medication for this antibiotic, for this infection, right? We started tracking and trending it, right? We have 13 different diabetes medications, and then we realized that the thiazolidinediones don't work, right? They cause CHF. That's not great. Let's use this one over here. It has the best outcome. Look, they lost all this weight, and that's what's going to help. Okay, and then best surgery, like I mentioned. Is it better to do a laparoscopic surgery versus an open surgery? So they found that the healing rates were better, right? So like open heart surgeries, like everybody got open heart surgeries until the 80s. Everybody had, when you had a heart attack, crack it open, all right, let's go. And they started, bypassing the occlusion. But nowadays we can do an endovascular approach. We can go into the cath lab, go in there and take out the clot. And then we have like organ transplants. That wasn't a thing before the 80s, 90s, but you could transplant someone's organ. You get a brand new kidney if you had end-stage renal disease. All right, so the aging population now live longer, and they have more disability, unfortunately, and more chronic disease because of all these advances that we have. So we have to decide, is like, well, how long do you want to live? And if we do this treatment, you might have bad outcomes. Right? So we have to decide, do you want a tracheostomy? Do you want a PEG, a percutaneous endoscopic gastrostomy, a feeding tube? Do you want chemotherapy? This chemotherapy is going to cost you $200,000, right? Do you want to spend $200,000 on this chemotherapy? You might live 21 more days, or you could spend those 21 days and go off and do, take the vacation of a lifetime, right? You could buy 3 boats. You can do all kinds of things with that money, right? That's a huge financial impact. And just that's not even saying, maybe 21 more days, but then the chemotherapy itself could cause all kinds of complications. It could shut down your kidneys and cause your heart to go into CHF. There's all kinds of complications with chemotherapy as well, right? And in addition to the other medications that we provide patients. Okay, so often patients are not aware of their disease progression. They show up to the hospital, it's like, and they're like in CKD stage 5. Oh yeah, I saw my doctor like 10 years ago, and they said it's some kidney problems. And well, now you might need dialysis. Now this is a really bad situation. So we have to identify before that point with our doctor visits, do you want dialysis? Because now it's 2 in the morning, dialysis or not, ma'am, what are we gonna do? So then it's like, oh yeah, sure, just do dialysis. I don't know, what's that all about? And often there's a communication breakdown as well behind what treatments we offer, because those are the treatments you can offer, but are they the right ones? Are they gonna be the right thing that the patient wants? So oftentimes we have these conversations in critical situations, but the idea is to discuss these things much, much earlier to decide if they need to have what therapies they're going to want with their disease process. COPD is irreversible. So when you have COPD, you will suffocate to death. That is what is going to happen. Either you'll suffocate to death or your lung will pop and you'll get short of breath and you'll suffocate to death. So what do we do? Because you will suffocate unless you get like a car accident or something. But what are you going to do when you get to the hospital setting and it's that point, right? Are you going to want intubation and want a tracheostomy, and then you have spontaneous pneumothoraces and your lungs pop, you get chest tubes inserted, and then now you may live 1 or 2 more months in absolute pain, and then that hospital bill is not going to be cheap, right? That's what do you want towards the end of your life? A CHF patient will drown to death. That is what's going to happen. Their heart is going to fail, and all the fluids go to their lungs, and they're going to die for that. So where do you want to stop treatment and consider palliative treatment? Just the symptoms. Let's give you Lasix. Let's up that Lasix to a whole bunch. Lasix not going to fix the heart failure, but it will not make you drown to death, right? And then, of course, when you're at the point where your heart is like 10%, 5% ejection fraction, what do you want to do then, right? So we could consider, I'm done. Okay, let's go to the physician. Let's get physician-assisted suicide, for instance. So there's a idea of like, what are we going to do towards the end of life? With CHF, with COPD, with end-stage renal disease, all these chronic diseases are very, very irreversible, right? So we have to figure out, if we can't get a new one, right, can't get a new heart transplant, not a new lung transplant, not a new kidney transplant, what are the next steps? Okay, so 92% of older adults, that's age 65 and older, have a chronic disease. They have CHF, they have COPD. We spend about $3.5 trillion per year just managing the last 30 days of someone's life, right? So with the last 30 days, should they be in the hospital, or do they want to be around, with their family and just die at home instead? Okay, so end of life discussions are critical. Shouldn't be critical when they are critical. It should be towards, and whenever they are, we saw the graph of CHF as they decrease in function over time, right? So when they're, halfway point, we should start discussing, I can add this medication. It's going to cost you like $800,000 a month. It could be finance related, or this medication could have its own complications that we have to consider. Or they could have other treatments, like with extended heart failure, they can get the cardiac resynchronization therapy, right? Little pacemaker wires put in. The pacemaker wires can cause damage to the heart, they can cause all kinds of other problems. So we have to consider what are we causing suffering or are we causing healing? And it's a big determinant of, as providers, we have to say, am I doing harm or not, right? If I provide this medication and all these other options, and there's no light at the tunnel, are we doing what's best for the patient? Are we actually causing suffering, or are we actually causing healing? Right? So we have a lot of patients come to the hospital, COPD exacerbation, CHF, an MS relapse, an MG crisis, DK, HHS. So we have to consider with all these chronic diseases, they can have these exacerbation states that we have to think about, is this an irreversible thing or something reversible? DKA, you can fix that, that's no problem, right? But something like an MG crisis, they sometimes get into like 27, 30, 35, 45 times. So we have to consider, what are our end goals for these? What are our goals of care? Okay, so do they want treatment or do they want just the symptom management? That'd be more like for a COPD patient or a CHF patient. We can give you these breathing treatments for your COPD, but they're like, I still want to smoke. That's what I want. That's what I enjoy. Let me smoke. Well, let's have a discussion, because when you come to the hospital, what are we going to do? Are we going to do the full amount of care regarding CPR and intubation and all these other things? Are we going to give you a breathing treatment, or a breathing tube, or a chest tube to fix your COPD? If you're still going to be smoking, we want to support what they're doing, right? Of course, we're going to offer them smoking cessation, but we're going to say we have to have a discussion about what our goals are. Okay. So we have palliative care that we can offer at a certain point, right? So we have without treatment, they may die right here, but they might die about 2 months later, but they had all this extra expense, all this extra suffering that could have been added on top of their treatment course, or their disease course, I should say. So palliative care focuses on the relief of pain. There are 8 domains of palliative care. We're going to kind of use that as a structure for the discussion of palliative care. But your goal with palliative care is not to fix the symptoms, like not to be on the best of the best medications, but just to fix the symptoms, right? So there's curative care and there's palliative care. At a certain point, curative care cannot be offered anymore. There's no other curative treatment or procedure that we can do. So palliative care is really going to start taking over at that point. And if it's less than 6 months to live, then we can actually do what's called hospice care. So hospice care is included within palliative care. We do palliative care from the beginning. Hey, you're diagnosed with CHF. This is a stage 2 CHF, and these are your symptoms. I'm going to start you on these medications. This is what to expect. This is what you can do, and this is what is recommended. But how does that feel for you? What do you want, right? What do you want to do with your life? It's like, no, I still want to eat what I want. I still want to go on cruises. I still want to eat all the high salt foods. So okay, let's talk about what that can lead to your CHF declining. So what do you want? Once your CHF does decline, what are you going to do? Okay, so that's the idea behind introducing palliative care. So we can introduce these other palliative treatments. Something like a cancer, right? A cancer is compressing the bladder or compressing the ureters. So what can we do? We could say, well, we can offer you surgery to take that out. That cancer might be very, very aggressive, and it's gonna return. So do you want the chemotherapy, or do you want just the palliative surgery, the palliative treatment to be offered? So like cancer diagnoses, they usually they decline very, very rapidly at the end of life. Where something like CHF or CKD, they have these episodes of exacerbations, and they never return back to their function right here. So there's our level of function. So they keep declining over time, and we have to introduce palliative care at some point, right? Oftentimes, and unfortunately, palliative care is introduced at the very, very end, when they're in the ER or when they're in the ICU, or when a rapid response team is called to the 3rd or 4th floor. It's like, okay, we got to decide. You've been on all the oxygen therapies, and the next step is putting you on life support or putting you on a ventilator. So I never had talked about that before. So well, then you have to start the conversation then in 5 to 10 minutes. Whereas if we were discussing this at multiple points when they're in the hospital, or multiple points when they're with their doctor, then we can maybe have this discussion about when we got to that point. that point, right? And they can then discuss it with their family, which is also another important piece. You can see dementia is a rapid decline, right? It's not, they don't have exacerbations. They can have the complications of immobility and such, but their functional decline is going to get very, very depressed and very, very low very, very quickly. So we have to have those palliative conversations early, okay? So the focus of palliative care is, again, on the quality of life versus the quantity of life, right? So do they want aggressive interventions, or do they want to be able to do their ADLs? Do they want to be able to do their activities of daily living? Do they want to be able to run outside until they can no longer run? And then that's it. If I do need to get hospitalized, I don't want to go to the hospital, right? I'm going to have a paper in my house that says, don't take me to the hospital, okay? So we focus on symptom management, not the treatment. Okay, so we just focus on, like we said, the surgery for that cancer mass. We're going to just take that out. Okay, so what are we going to discuss? We're going to discuss, do you want to artificially be kept alive? Because a dialysis is just a kidney in a box on wheels. So we can roll it to your, you can roll it to your dialysis center, and you have to come 3 to 4 times a week, right? And that has a lot of complications in and of itself that we discussed. Is that something that you want if your kidney disease gets to the point where you need to have a replacement kidney, right? And same thing with mechanical ventilation. Do you want to be just put on the ventilator for 2 days, 3 days, 5 days? Or do you want to be on the ventilator for the rest of your life and die on the ventilator? Is that what you want, right? So we have to have those discussions hopefully early. Unfortunately, they are discussed much, much later. Okay, so hospice care, again, is how many months to live? Is usually 6 months. It's like, well, how do I know it's 6 months? You can renew it, right? If they have a really, really bad prognosis, really bad, like stage 5 kidney disease or stage 4 CHF, stage 5 COPD, you can renew your hospice, right? You are at your end of life, and that is your goal, is to relieve discomfort and relieve suffering. That is the goal of palliative, but palliative also is just like treating symptoms of the disease, whereas hospice is just treating the pain, just treating the anxiety, just providing what's called comfort care, right? We're only providing things that will not hasten death, but comfort you until you do die naturally. It's an idea of having a natural death versus an artificial death with all the different machines and things we can do in an ICU, ER, hospital setting, right? So here's some myths of and descriptions of hospice, right? Again, it's less than 6 months to live. It can be, people say, oh, I don't want to do hospice because I have to go to a hospital. It can be offered in the hospital if like super, super sick, but oftentimes we can take patients out of the ICU, put them on an ambulance, roll them into the house, and take the breathing tube out right there in the house. Oftentimes we try to aim to do hospice wherever they want it. And actually about 70% of your hospice is provided at home. That is the statistic. It's usually provided at home. Who can contact hospice? They want some changes, or they want some other things added for pain relief or anxiety relief. Anybody can call the patient or the family or such. There's a worry like, oh, once they're hospice, they've given up. But hopefully you've had the conversation ahead of time about where we're at, right? And then again, it can be renewed because that's the fear. The other fear is like it won't be paid for. Hospice is covered in every plan. The reason why it would not be covered if someone ordered morphine and someone ordered Dilaudid and someone ordered morphine again. It's like, well, I'm not paying for 2 morphines. That's what the insurance company is going to say. But they are going to support pain management. They're going to support anxiety management. They're going to support like bowel regimens and such. Those will all get paid for. Unfortunately, palliative treatment does not always get paid for. So that's people say, no, you need the treatment. It's like, well, it's a whole thing because you get a lot more reimbursement for a hospital setting than you do for the medications. So there's a little ethics there for insurance companies. By the way, how's it paid for? Insurance will pay for this. And then what is not covered is like duplicate therapy. There's myths like I'm giving up on living. It's like, well, what is living? Is living where you're on a ventilator for 30 more days? Or is living where you can go out fishing for the last 30 days and you can be brought to a boat somewhere? Or you can be live your life on a cruise ship for the last 30 days versus spending $20,000. How much would it be for a 30-day cruise? I mean, you see deals like $400 for a week. So you could spend all your time doing that, or you could spend about $300,000 on average is how much is spent at the end of life. So there's a money thing is important. It's like, oh, how much money can I put on a life? It's not that, but it's also how much money can I spend on other things that I want to do, and what I could do with quality, right? What can I do? I can spend time. Let's go to the movies every day. Let's do this every day. Let's do that. So you have all these things you can do. And if you're getting these treatments with the chemotherapy or the treatments with their heart failure, treatments for end-stage renal disease, that can then lead to them being too fatigued to do these things or too out of breath to do these things, right? So we have to figure out what kind of treatments they would need and what kind of therapy they want, right? That's the idea behind palliative and also the idea behind hospice, okay? There's myths like, I have to leave my house. That's not true, right? And the other one is like, my doctor will let me know when it's time. The doctor, they're actually waiting for you. They're still waiting for you to bring up the conversation. So ideally, as providers, we have to say, have you thought about where you're at in your disease process? What has your doctor told you about this? What do you want? What do you not want? So those conversations should be happening much, much earlier. And unfortunately, they're happening much, much later. Okay? Many MDs and providers wait until it's too late, right? But we can offer hospice even on, like in the ICU. We have patients that go to hospice care and they die an hour later. Or they can be brought home and they can then be, die with their family and die like a week later. So we have to, breach this idea of providing hospice either early, especially if it's less than 6 months to live, or at least palliative care. Okay, so the framework. So there's about 8 different phases of palliative care. We're just going to kind of focus on this. Should make sense. We're not going to get too detailed, but it should make not theoretical sense. It should make sense on, let's look at the structure of palliative care. How do I implement palliative care? You have to, again, have those discussions with them at hospital visits, at clinic visits, at doctor's visits. So we discuss what their goals are. It's your goals of care discussion. And it's important that the family is present too, because you don't want to just have like a private conversation in a room somewhere, and they come out, and then when the patient gets admitted to a hospital, say, oh yeah, we talked about that, and but the family wasn't involved in that conversation. So we want everyone involved. So we're identifying goals. We're educating what is the end stage CKD look like? What does end stage CHF look like? Where are you at in your progression? There's a lot of documentaries out there we can show. There's all kinds of things we can show as far as what are the next steps in their disease process and what are their goals if they get to the point where they need life support or they need aggressive interventions, right? So there's different documents that we'll fill out that we'll discuss. And we discuss like where are they at in their disease process? Do they need palliative at this point, or do they need hospice at this point? So we want to make sure we are discussing that those goals of care. So focusing on the education of the disease process, focusing on interdisciplinary things such as they can get mental health support, they can get support from a physical therapist, they get support from an occupational therapist. These are things we want to make sure everybody's involved with. All right, so domain 2 is just the physical aspects. It kind of collides with 3, which is your psychosocial. So we assess their physical needs and their psychosocial needs. Do they have anxiety? Do they have pain? Do they have depression? Do they have are they eating well? What's their level of, do they have wounds? What's their neurostatus? So like a dementia patient, where are they at in their Alzheimer's? Right? What's their mini mental state exam reveal, right? How short of breath are they? How far can you walk? So these are objective ways to assess where they're at and whether we can jump in and say, on their disease process, if they need to have have palliative, say, hey, we have options. It might not be curative, but it can actually be more a palliative approach to assist with your symptoms, right? Or assist with their anxiety. We have anti-anxiety meds. Do anti-anxiety meds affect CHF? No, but if they have all this dyspnea and exertion, we can give anxiety meds to help. These are like palliative support. So it should be at the same time, right? They shouldn't have to deal with CHF by themselves and then get anxious in the hospital setting when they're short of breath. We want to have those things available to us, okay? There are standardized scales out there, but really for anything, like care plan wise, you can make anything on a scale of 0 to 10. That's going to work. It's like, what's your anxiety? It's 0 to 10. There might be some magical scale out there that measures it, but 0 to 10 is fine, right? Your scale is, are you have 0 anxiety, 5 anxiety, or 10 anxiety? Same thing for depression, 0 to 10. Same thing for suicidal ideation, 0 to 10. What's your pain? 0 to 10. Okay? So psychological also can do with grief and loss. So what is the, how much grief do we have with the diagnosis of a terminal illness or the diagnosis of or even if a patient dies? What are we doing to manage someone's grief, right? Usually ahead of time it might be the patient might have this, the family might have this, and sometimes you go through this whole range of emotions. And those range of emotions are DABDA, or DABDA. So you got denial, you got anger, bargaining, depression, and acceptance. And sometimes the family is far behind what the patient has accepted. So the family might be extremely angry at the diagnosis and the likelihood that they might have a terminal diagnosis, right? So the goal is to support them through these situations so that they know what to expect, but also to support each one of these stages as they occur. So he has anger over the diagnosis, anger over the situation, and anger over loss. Okay, so anger is one of the first two emotions that are dealt with when we have a diagnosis that is terminal, or even a loss that occurs, right? So we have these different stages of loss and grief, right? So it's called DABDA. So denial, they're denying what's going on. They're like, that's not true. I don't have that. What is this? I don't have this diagnosis. I can't, they're confused, they're shocked, they have fear, they're numb, they're speechless. These are signs of denial, right? Examples of what they would say is, this is a mistake. You have the wrong file. Those are the wrong labs. That's not me. We'll go on a vacation as soon as I'm better. They're denying the diagnosis, right? And they might question everything. They say, is this the right thing to do? Should I be on this or that? Right? So again, the idea is to support their denial, but also not support the denial, but be as factual as possible. And they might be consciously doing this or unconsciously doing this denial phase. And usually it's always the first one to not usually always, but usually it is the first one to present. But usually the experience can be very, very jumbled. It is presented in this order, but it's not always the order it presents in. Someone might be angry first. And what does anger look like? Right? So they're lashing out towards friends and family. You go in the room to check their AccuCheck, and they yell at you. They throw things at you. They call 911 on you. These are things where they are angry, right? They have frustration. They have aggression. They might have a lot of anxiety and shame. These are, and some examples is like they might be yelling and saying, why can this happen to me? This is your fault, to place blame on someone specifically, okay? And it usually happens after denial. Well, they can't really deny it anymore, and now they have realized that they have this terminal diagnosis, they have this problem, and they are going to lash out because of it, okay? So encourage those around them to keep them detached. It's not them. They are going through this phase on their own. It is a stage of acceptance, stage of not so much dying, but this can also be attributed to not just dying, but like divorce or to loss of a pet. All kinds of other different things can be attributed to this. Okay, so we have denial, we got anger, we got bargaining is next. So bargaining is where they are saying, I'm going to do this for that. I will be a better father. I will be a better person, faithfully, right? So I'll say I'm going to go to church now. So they really are going to sink in on a religion. They're going to make deals with God. They're going to go to the highest priest in LA County. They're going to go to the archbishop. They're going to go to Rome. They're going to get blessed at some font somewhere. They're going to do everything they can religiously to try to fix their disease process. Right? So if you cure this lung cancer, I'll never smoke again. So they're making bargains. Okay? So give me one more year and I'll be a better father. These are ideas where they are at the point of bargaining. They haven't accepted their disease process or their diagnosis. They are bargaining. And then we have depression, right? So depression is where you are depressed, right? So SIG ECAPS is a mnemonic you'll learn in psych and how to fix it, and medications for it and such. But here they're going to have they're recognizing the inevitability of death. They're very depressed, withdrawn. They don't find joy in the activities they used to do. They have really decreased energy, right? They might be grieving already. Whereas progression from that is acceptance. So acceptance is where you have accepted the diagnosis. You're not showing any other signs. You are preparing financially for your family. Like Walter White here is preparing for his family. He had a lung cancer diagnosis, and then he went out and made himself, his family set up so they are going to have the funds available to pay for the burial, and also paying for your own plot of land, paying for your funeral itself, making sure people are financially set is another feature of acceptance, right? You have a calm demeanor. The family might not be at the same level you are, but they are, they might be going through anger themselves. They might be in denial themselves, but the patient may have already accepted their death.
My role is forever and ever. You're gonna make this world a better place. You're so strong.
After a 5-year heroic battle with a rare cancer, Ryan Cameron Forbes died on December 11th, 2023, surrounded by the love of his family at the hospital. He was just 45 years old.
This is always like
That's okay.
It's okay. Smile.
He was cherished and survived by his wife, Julia, their child Lola, and puppy Honey Bear. This video reflects Ryan's incredible heart and strength. Often it was him that was comforting all his loved ones, despite the immense pain he was battling. His obituary said the following: Ryan was the essence of the small town he grew up in. His heart, infectious smile and compassion made him a friend and family to all who crossed his path.